Hi, everyone. This is Joni McGarry. Thank you so much for tuning in. My guest today is Professor Garrett Wallace Brown. He's the chair of global health policy at the University of Leeds in the UK, and he is also co lead of the Global Health Research Unit and research collaborator with the WHO on health emergency evidence and analytics. His research focuses on global health governance, health financing, health system strengthening, health equity, and estimating the costs and funding feasibility of pandemic preparedness and response. He's conducted policy and research collaborations in global health for over 25 years, and he's worked with NGOs, governments in Africa, the UK's Department of Health and Social Care, their Foreign Commonwealth and Development Office, the UK Cabinet Office, the WHO, the G7, and the G20. We're going to talk about his work on two multidisciplinary initiatives: the Repair Project, reevaluating the pandemic preparedness and response agenda, and the International Health Reform Project. Garrett brings a highly informed view to this topic based on his years of experience and his circumspect approach to the materials. It was a great talk, and I'm really excited to share it with you. So, without further delay, let's welcome Professor Garrett Brown. I'd like to welcome Professor Garrett Brown to the show. Thank you so much for joining me, Professor Brown.
Yeah, my pleasure. My pleasure.
It's very good to see you. Before we get going on the topics we were going to discuss, do you want to give a little background about yourself for our audience?
Sure. I'm professor of global health policy at the University of Leeds in the United Kingdom. I'm a health economist and epidemiologist who works largely on health financing and global health financing and health system strengthening, usually in the African context. But since COVID, I have moved more into emergency preparedness and pandemic preparedness. Um, my sort of policy background is that I have been an expert consultant for the G20 and the G7. Um, I work with the WHO sometimes. I've worked as a counter verifier for the World Bank and some other global institutions. And through that, I've been involved a little bit with the pandemic agreement, consulting with some countries in Geneva, and currently with the what's called the IGWG, which is a negotiating body trying to figure out what's called the PAPS annex of the pandemic agreement. And there's a lot of discord and contention around that, and I get brought in to sort of answer technical questions for countries that are under resourced.
What does PAPS stand for?
It's pathogen sharing and beneficiaries. So it's basically within the pandemic agreement, there's an article that would require states to send in their latest pathogens to a WHO central source, which is in Germany, the Global Biohub, and that what benefits they would get from participating in that pathogen sharing system. And that's what they're trying to figure out because at the moment, there's a lot of obligations to share data
Hmm.
and not a lot of obligations for the beneficiaries of that data. So those who are a lot of outcomes for the beneficiaries of those data. So it looks like now that many low and middle income countries are being asked to send in their pathogens, but if there is a countermeasure produced from a pharmaceutical company for that pathogen, there's no guarantee they would have access to it.
Oh, wow.
So
Okay.
so there's no benefit from being part of the system. So they're
Right.
asking, "Well, why should we do it?" You know, so
Right.
there's a large debate around this because they were saying that, "Well, surely we should get a diminished cost per unit or something for being participants. What's the benefit to us for
Right.
spending the money to do all the surveillance and diagnostics and send things upwards when there's no guarantee we would have any benefits of the outcome from that?"
Right.
So
Oh,
I'm sort of helping them negotiate that. Some of the
okay.
countries that feel like they're getting the hard deal, I
I
think.
see. Well, one of the more global, and I don't mean this like in your context, but the high level things that I wanted to talk to you about today is you have experience, obviously, in global public health prior COVID and now
mm,
post COVID and during COVID. And the landscape has changed a lot. And you
mm,
have worked in some independent study groups to look at how that's shifted and what the impact is on smaller countries that have a disease burden of chronic
mm,
diseases
yeah,
versus and that used to be the focus of public health, and then during COVID something shifted and it seems to have
yeah,
gone to biosecurity. um, Now, you worked on in a multidisciplinary group called Repair, which is reevaluating the pandemic preparedness and response agenda, and that's
yeah.
based at your university. Can you talk a little bit about that work, um, and what you've learned in that about how public health at the global level with the WHO has changed?
Yeah, I think let me give you a little starter to how this project took off. Is I was asked by the WHO and World Bank to be part of many research teams to do an evaluation during COVID of what proper pandemic preparedness would cost and how we could finance that. And this was to go to the G20. It was to be in a report. They gave everyone 3 months to do this, and there was all these different teams working together. So I pulled my team together, and we got some data together, and we provided some data, but when the report came out, it looked nothing like what I thought it would look based on the data that I had provided. And so I started looking at the report a little more closely, and I realized that it was just absolutely a shambles, that it didn't have the evidentiary quality that you would want when you were asking for that kind of money, to be spent on a pandemic. So, an unknown pathogen of unknown severity, of unknown frequency, of unknown treatment, um, and to invest that kind of large money. And working on the financial package of that report, I was thinking, geez, I don't know how they got that. So it sparked a curiosity in me.
Mhm,
Um, I pulled together a group of academics and consultants and experts. These are people that have worked for the WHO or worked in other international organizations. These are academics, postdocs, PhDs. In total, there's been about 20 of us working on this. And our main focus was to spend 2 years examining the evidence base in which the entire new post COVID pandemic agenda was being built upon. And that was kind of threefold. One was, what is the risk of pandemic? What is the risk of zoonosis spillover? What should we be trying to prepare for? Right. So, what's the baseline? Right.
mhm.
That was it. What's the evidence suggest? And what are they saying? And what does the evidence suggest? Both the evidence they're citing, but also other available evidence. The second one was the costing. I went back to the costing. I mean, how have they estimated these costs? How realistic are these costs? How realistic are their financing models and the return on investment calculations?
And I just and when you say "they," you mean the WHO, or is it
WHO,
or is
it's
somebody else as
writing them.
well?
No,
Okay.
well, one of the key reports we looked at is that World Bank WHO report on the costing gap. But there's many others. I mean, there's the high level independent panel from the G20. That was a group led by Larry Summers, who was a former World Bank person. Um, they did their own report. There's the Global Monitoring Board. They did a report. There was a lot of reports during
Mhm.
COVID about, how do we get a handle on the next big pandemic, which is a fair question.
Sure.
Um, and we started looking at the evidence they were using. So we looked at a series, what evidence was available at that time and is
Mhm.
still available, it's still being used. And we investigated these questions, how good are their cost estimates, financing estimates, how good are their risk assessments? And then we also had a package that looked at, well, how are these things coming together? What institutions and policies are being devised? What lessons do they think those policies have learned from COVID? Who's leading these initiatives? How representative are these initiatives? And is this going to be fit for person? What's the cost of, and I don't mean financial costs, that was something else, but what's the overall cost of public health if we continue down this road? So we looked at those three things, and we did that for now 3 years. We got an extension because we did so well in the first 2 years. We found we uncovered so many problems, and we got another extension. So we did it for another year. And we're wrapping up in the end of July on that
Uh,
project.
and when you say you
And I can
uncovered
tell you,
I know, I'd
Yeah,
love to hear more about that, but just wanna point out that your research included their own data on
yeah,
which they based their own conclusions, so you didn't have to
yeah,
speculate what numbers were going into their analysis, is that
no.
correct?
No, yeah, we used entirely their own
Okay.
evidentiary
Alright.
material, their own data, um, and just analyzed it more carefully.
Okay,
Um,
and so what did you find?
well, we found I mean, in a nutshell, we found that their risk assessments have been grossly inflated. So, how they did their modeling was really basic in the sense that, all they did is count the number of outbreaks that have occurred, um, and they graphed them out. But they didn't really analyze why that could be the case or counterfactuals to why that could be the same or confounders for why that would be the case. And we found a couple things that were omitted from their analysis that we thought were important. The first thing we found is if you look at the graph, you'll see a spike in 1983. And so we said, well, that's interesting. What event took place in 1983? Nothing. What took place was is that's when PCR technologies were invented.
I
And so
see.
what you see is as technology has increased to detect these very small outbreaks, you're going to get more of them recorded.
Well, of
But then
course.
when we lay that up against disease burden, okay, but all right, there's more outbreaks. That could be concerning. Or is it the reporting, or better detection? Okay, well, we can tell if what is the disease burden associated with each one of those outbreaks, and it's very low.
Mhm.
For example, and maybe your viewers don't know this, but Zika, MERS, SARS, the first time all killed under 1,000 people. You wouldn't think that because the way it was portrayed in the media, it was,
Right.
it must have been hundreds of thousands of people, but it's less than 1,000 people. So the disease burdens against these very low out these outbreaks is very low.
But the graph
You just
showed the data points were 1 outbreak.
n
They weren't weighted for disease burden.
no, not at all.
Okay.
So it was
And
just counting the number of detected or reported outbreaks.
okay.
So that's one thing we found was just that with the growth of technology and the better ability and the more funds and the more people looking for these exotic pathogens, the more likely we are to find them,
Mhm,
and that could largely explain that. Um, and that's great, but then you have to look at the disease burdens that are attached to them, and we said, well, okay, well, most of these would have never been found beyond background. They would have never stood out uh, from background if you were to just look at the sort of the burdens of a country. It's because we have located them that we then make them stand out from background and put them on a graph with a bubble that
mhm.
would normally not be there. So that's one thing we found. We also found that the way they calculated severity um, was basically just to take a very crude average. What they did is they just sort of went back to the 1200s, looked at the number of people who have died from pandemics, and then uh, adjusted that number for population growth and just used that kind of hard, blunt number. So you get numbers like an average of 2.5 million people per year die of pandemics. That's from the golden burden of disease, right?
But
And
they
that's
were that's from the 1200s, and then
yeah,
they extrapolated the death rate in the 1200s to now? I can't
yeah.
possibly have that right.
No, no, that's absolutely right. So that's the golden burden of disease is one group that's done that. But what they haven't accounted for by doing that is, well, that's pre-antibiotic. So even including the Spanish flu is a bit um, of a cheat because that's
Right.
pre-antibiotic. That was during the First World War. We know that most deaths were from secondary bacterial infection. Um, we also know that economic hardship drives disease burden. So all those factors together. Um, Most of the models we looked at included the Spanish flu, even though they said they were going to look at 100 years. They added that because they said, well, there's no other really good data point. We need to have something in there, so they just included it in there. But the global burden of disease went even further and went back all the way to 1200, including the plague. So of course, when you then adjust for population, you're going to get these astronomical numbers, which is, according to the Global Burden of Disease, 2.5 million people per year die of pandemics. But you can only get that kind of astronomical number that totally defies intuition by going back to the 1200s and doing the modeling the way they did the modeling.
Do you suspect that the modeling was done with an agenda toward making it seem heightened to fund an engine that would be a whole new pandemic response globally? Or do you think it was just a fear based out? I mean, I guess you can't
I don't
speculate as
know.
to intention. Um,
I, I, I mean, I can't say this with a level of assuredness because uh, I think these so-called evidentiary documents are really political documents nowadays. So when the high-level independent panel produced that report for the G20, they were doing that as advocacy for a more sharpened
mm,
pandemic preparedness uh, regime.
I see.
I have no doubts about that. The other thing, I think the WHO World Bank report that was done very shabbily in 3 months also had that. It was almost when we were working on it, the number was already kinda known, and you were working towards proving that number.
Hmm.
And suspiciously, that number is the number that was already priorly given in a report a few years before COVID from McKinsey& and Company on the same subject. And when you look at the high-level independent panel report, and you look at the WHO report, and you look at the McKinsey report, the 3 reports which the costings and financing modeling was done, they all kinda come around the same number and the same and they cite each other as if there's this large evidence base, but they're actually circular citing each other.
Hmm. Hmm.
Um, this is verified by the World Bank report, but then they're citing the World Bank numbers. So
Hmm.
just because the World Bank just said, "Yeah, those are the right numbers. That's what we put in our report." This doesn't mean it's verified. It just means that,
Right, right.
it's like that they agree with you. So these type of things were going on that we found both with the pandemic risk modeling, but also with the financial modeling. And I'm happy to talk more about that because some of those things are just such rookie kind of 101 errors that
Hmm.
it's hard to believe. Even when we got that reviewed, we got an article reviewed, and the reviewers came back and said, "You got to double check this. You guys are wrong. There's no way. You sure about this?" So we literally had to cut and paste the section from the report and put it in our response to the reviewer saying, "These aren't our words."
Right.
You know? I'd be
Yeah.
happy if they were because then we wouldn't be making such dumb decisions. This is from the report, and then the reviewers wrote back saying, like, "This has to get published because if that's the quality of the report, we thought it was such an error it couldn't exist."
They thought that you had such an error because you were such an
Yeah,
outlier. Yeah,
yeah,
you were lowballing it so much because the official narrative or the official reports were so much
yeah,
higher.
yeah,
Um,
and it was a simple thing, and the return on investment calculation given by, um, the WHO World Bank is that you can mitigate 100% of an epidemic excuse me, of a pandemic costs. 100% of the cost can be mitigated with the 31.1 billion a year for 5 years investment. That's the return on investment. So, basically, for that amount, you can save $14 trillion, dollars, which was the estimate of what COVID cost. But that was also the 100% estimate of what they thought COVID was. So there's no health economist in their right mind, anyone who does return on investment would ever say you could mitigate any outbreak 100%. Meaning, just look at the hantavirus on the ship. That's probably already cost 100 million.
mhm,
Um, there is going to be a cost to any response,
of course.
to any outbreak. So to suggest that you can have 100% return on investment, it's just so rookie that the reviewers thought this can't possibly be there. But then when we showed them the graph, they're like, "Yeah, it says 100%. Okay."
So let me ask a question then. So these numbers are being established by these legacy or large, powerful groups.
Yeah,
These reports are made, and then the organizations that are doing global health set about to have these giant budgets to put all this scaffolding in place to prevent this catastrophe that's definitely
mm,
coming based on these
mm,
numbers.
yeah,
Um, Let me just say an argument for that. Like, just say, okay, so that's great. It makes us all safer that we should have all these things. Why isn't that true? And what is the cost of doing it like that? And I'm not suggesting we should do
yeah,
anything on false numbers. I'm just saying that there would be an argument from
mm,
certain camps who say, well, look what happened during COVID. We should have all this structure in place. And I don't think
yeah,
they would account for the fact that the response to COVID was not necessarily a public health response
mm,
that we would have practiced before COVID.
yeah.
So what is the downside of overestimating these numbers to actual public health in the
Well,
globe?
the first downside is just the opportunity cost of doing so, right? So if you take the numbers at face value and say, okay, this is what it actually is really going to cost, and we just assume they haven't inflated those or taken a small sample and extrapolated numbers that just are totally incorrect. Let's just say that these are the true costs. So the true costs, supposedly, according to WHO and World Bank, and these are the costs that were presented to the international negotiating body on the pandemic agreement in a PowerPoint slide by the WHO. I know because I have it. Um, and because I was also part of it, a part of the Article 20 subcommittee. Um, the overall cost for preparedness is estimated to cost 31.1 billion a year. 10.5 of that is going to be new ODA, official development assistance from international donors like the United States, England, the usual suspects. 26.4 billion of that is going to be from low and middle income countries. Now, 26.4 billion in additional resources from low and middle income countries, some of which struggle to keep clinics open, staffed, stockouts, all the problems that they have, is a pretty big ask. Now, that's just one component. What's not included in those costs are what they call manufacturer readiness. The amount of money that it would cost to get pharmaceutical companies the capacity to be ready to manufacture large countermeasures at a moment's notice, right?
And to carry that capacity fallow, not
Right.
working. Yeah.
Yeah. So the estimated cost of that it's been estimated by two groups. The lowest I've seen is 29 billion over 5 years with 2 billion per year for upkeep, and the highest I've seen is 60 billion over 5 years with 2 billion for upkeep.
For something that
Um,
might never happen.
for an unknown pathogen of unknown severity, of unknown frequency, of unknown, you
And
know,
based on
there's
based on what you feel are inaccurate numbers of the disease burden
yeah,
that is
on
likely. Okay.
yeah, on inflate. I mean, of course, pandemics come and they can be deadly, and depending on the pathogen, they can be very difficult to manage. But historically, um, and we'll get to this, COVID is a bit of an outlier. And we'll get back into,
Mhm.
was it COVID or was it the response? Well, how do you weigh the cost benefits
Right.
of that and the cost of that? But just get back to the key costs they're suggesting. Another 11 billion would be required to implement One Health sufficiently, according to the World Bank in a different report. Now, One Health is this integration of farming and animals and human health and what they call integrated surveillance, which is very expensive to do. You need veterinarians alongside doctors and laboratory networks and stuff. So that's an additional cost. And none of that includes response. So whatever a response cost would be um, is not included in those numbers. But when you add it all up at the end of the day, for that initial 3 year period, 3 to 5 year period, it could go as high as $250 billion that would be required to do it what they think properly. So that's a huge cost. What would $250 billion do if spent elsewhere, right? And when you look at the disease burdens that we're talking about, okay, MERS under 1,000, SARS under 1,000, Ebola somewhere around total 18,000 in all of its multiple outbreaks, Mpox under 1,000,
And these are deaths, under
and
1,000
these are
deaths.
deaths. Yeah,
Okay, yes.
these are deaths,
Mhm.
and deaths are bad. But, 600,000 will die of malaria this year. 1.3 million will die of tuberculosis this year. Um, HIV, that's just communicable diseases. If we start thinking about non-communicable diseases, we have growing non-communicable disease burdens.
And what would those
Those
be? Just for would those be
oh,
like malnutrition, starvation?
those for sure, and cardiovascular disease, the biggest killer, right? That's the
Okay.
biggest killer of people.
Right. So I think it's
L
really important to put the mpox and uh, Ebola and all those death numbers against that annual
Yeah,
background that's always going on.
yeah,
And some of that is very preventable with the right
yeah,
public health response. Okay, go on.
and so yeah, and many of these we know what to do. We know how the virus or the parasite or whatever it is we're fighting operates. We know that nutrition can play a major role
Mhm.
in, immune response, but talking about opportunity costs and talking about nutrition, since COVID, nutrition official development assistance for nutrition has dropped 11.1%, right? Basic health in ODA, a category in official development assistance called basic health, fell by 32%. So we see the shift in resources already occurring towards this pandemic preparedness agenda, which is really just surveillance, diagnostics, and countermeasures, right?
So the money that used to go into those basic assistance programs is
Has been
now
shifted.
migrating. Okay. Let me just take a moment to tell you about Crowd Health. If you're paying high health insurance premiums, you're going to want to know about this organization. Crowd Health is not health insurance, but it's enabled me to quit my health insurance. I joined Crowd Health instead. It's a crowdfunding platform where members fund each other's medical expenses. You pay $60 a month to be a member, and then once a month, you're asked to help fund another member's bill. You always know upfront what the maximum monthly ask will be, and most months it's less than that. In 5 years, CrowdHealth has funded 99.9% of all funding requests. I'm saving thousands of dollars this year, literally, and I really feel covered. So to join, you just have to be under 65 and reasonably healthy. They have no enrollment periods, there's no waiting. You can join today if you want. So check it out at joincrowdhealth.com and use the code JONI, JONI, for a discount on your first 3 months. The links are in the show notes. Now let's get back to the show.
Yeah. Yeah, I mean, these numbers are on you go to the, OECD website, and they have, their official development assistance numbers per year,
Mhm.
and they have, um, various groupings, so health is one of them, and then they have various line items underneath each one of those groupings, and you can look at it year to year,
Mhm.
and you can see that, these have dropped,
Okay.
uh, since COVID, and they haven't recovered. They're not recovering. The money is still being earmarked for surveillance. Some money is still being earmarked for COVID, believe it or not,
I believe
official
it.
departments. So it's we have already seen these opportunity counts, this shift in resource and prioritization, and that's, I think, the major cost of these numbers, right? Is because they're unreachable. First of all, no one thinks they're realistic, but people are striving, and they're still using them as the ideal, and that just changes priorities,
Mhm.
changes resource allocation, creates opportunity costs, and and if you want to get really crass about it, if you spend more money detecting things, you're going to find them.
Sure.
Now, whether or not that merits a full scale response or not, that's questionable. It depends on the pathogen. But look what's happened recently with Ebola or Mpox or the hantavirus. I mean, these things have been escalated to almost, you know, it got so bad that even WHO had to come out and say, look, this can't be the next pandemic. Can everyone just slow down a little bit?
Mhm.
Because there was so much pressure on them to make
Mhm.
that public announcement. Because, in this country, we saw um, the BBC had a picture of a bunch of soldiers pull parachuting out of the back of a plane onto
Saw that.
the world's most remote inhabited island to make sure that someone isolated properly. It's just
Well, it seemed a bit
this is
theatrical
what
to me.
this is
It's
what
ins
happens when you securitize these kind of
yeah,
health
yeah.
programs, is they just become everything is a justification for extraordinary measures, whether or not they're useful or not.
Do you think it's easy to do that in terms of fundraising? Because the people most impacted by reductions in funds for nutrition and basic sanitation and things like that are people in very poor countries.
Yeah,
So that it's easier just to make them non human
yeah,
and go for all the shiny things, and, it seems that way to me, and then also, there's a lot of could you talk a little bit about the corporate incentive to, raise this kind of money? I mean, it's certainly there's certainly profit to be made as well, which I'm not saying people shouldn't make money from doing their business. I'm just
yeah.
saying that I wonder if how much incentive goes into that fundraising for $31 billion a year.
Well, right now we're running a project, and I don't know the results of it because the team is deeply in the midst of the data, but we have a work stream on the corporate determinants of pandemic preparedness where we're looking at this question, and that report will come out in September. Once we get all the final data, we're looking at secondary data of corporate declarations and all sorts of stuff to kind of see how uh, profits made and how various corporate entities, not just the pharmaceutical industry,
Mhm,
there's lots of medical product companies interested in this, um, where their incentives lie and how they've been able to steer the agenda. So that will be coming out. But I think in the short, I can tell you that there's a lot of perverse incentives by a lot of different groups. And I've called it this sort of aligned interest theory, where
mhm.
it may not be some back room of guys with cigars
Right.
and three-piece suits um, hatching plans, but there is this kind of natural aligned interest taking place. So the WHO has seen the coronavirus as and the pandemic as sort of the way to reassert their epistemic authority in the face of competition from Gavi, CEPI, Global Fund, you name it. There's lots of initiatives that have crowded the space, and they're all vying for jurisdiction. So this was a way for the WHO to get a bigger budget, which they did for a while, um, to get more epistemic authority and to make themselves relevant and to really
Mhm,
take control of the narrative in a way that they were supposed to actually
mhm,
be representative of, you know, 194 states. And so they have a vested interest in this. We also see that, obviously pharmaceuticals had a bit of a windfall when it came to the vaccines and making countermeasures, all sorts of countermeasures to flus and whatever else there is. And that they have a vested interest in there. And their perverse incentive is to get on these boards and to make sure that their voice is heard
mhm.
and maybe even underwrite some of the other movements that are necessary. You think NGOs and CSOs, the representatives of the unvoiced, they also have an incentive here to make this big and bold because this is a source of revenue for them, of epistemic authority. Often, groups like the WHO and the Global Fund and others, they don't implement on the ground. They use third parties to implement on the ground, or the state will implement on the ground as a partner. But often you'll see, like in Zimbabwe, their entire performance-based funding model is implemented by court aid and crown agents. You know,
So tell me more about that. What does that mean?
so there's a $350 million fund given to Zimbabwe for child and maternal health, and it was this 27 indicators that had to be met and certain programs that the money had to go to, and you get money for every indicator that you reach, every benchmark that you reach, you get another tranche of money. Now, to implement that program, it wasn't the World Bank and it wasn't the other partners like the Norwegian Development Assistance Group and all this other stuff. It was Court Aid, which is a NGO out of the Netherlands, and Crown Agents, which is like a consultancy firm. And basically, what they did is they, with the Zimbabwe government, implemented the program, monitored the program, and let everyone know when those tranches were being met.
Mhm.
So they have a vested interest in making sure that this money comes along. Now, this had nothing to do with COVID
Because
or anything to do with
they're
any.
basically paid they're paid consultants or paid operatives to implement the program. Okay,
Yeah. So they're concerned about the sustainability of
sure.
their NGO or their consultancy, and so it's in their interest that these type of programs continue. And it's no different for pandemics, except for there's a lot more money,
Mhm.
right? Talking 31.1 billion. a year that's available for these things, not including manufacturing capacity and all this stuff. So everyone's sort of getting in here in these aligned interests. And that seems to be going on for sure. And pharma's part of that. Of course they would be because they have a vested interest in it. That's their, they
What they
have an
do.
obligation to their shareholders to
Right.
maximize their profits. So they're going to do that. They're going to figure out ways to do that. You also have philanthropists like Bill Gates, who's obsessed with technology and biomedical solutions to the world's health, and so he's pushing his agenda, which is aligned largely with pharmaceutical companies and other biomedical companies that are interested in that space. So that has definitely taken place. And if you're at the meetings and you hear who's being invited on the committees, it's these usual suspects. And
Mhm.
sometimes it's the same person sitting across six committees. And, you know, so that view is being inserted in those
Mhm.
six different committees.
Mhm.
Well, Larry Summers is a perfect example because, he's a noted health economist. He has some World Bank experience. Uh, and he chaired the HLIP, but he sits on a series of other committees too. And so the same people are writing these reports and different reports and same people, it's like
And they're all referencing each other, and, the
mm,
ball gets rolling.
it's
Um,
enclave thinking.
Right. So one of the things that happened, and heard you speak about it too, at an event in the past, when people were talking about the U.S. exiting the WHO,
Yeah,
and everyone was like, "Oh, that's just great! It's perfect." And I think some questions were raised about how does that impact actual public health in countries that really need it. I don't
yeah.
want to have this conversation go by without discussing that. And again, I'm not advocating for us to be in it or whatever. I just think people don't realize the full picture, just like you're trying to paint the full picture of public health with pandemic preparedness versus actual public health for ongoing disease states. So, what is the impact of larger countries leaving the WHO? Why might they do that? And how could something else look?
I mean, the problem with the US leaving the WHO is they no longer now have a voice at the WHO. And I'm sure a regime change in the United States back to Democrats, they'll rejoin the WHO and it could
Right.
be significantly weaker and even worse off than it is now. I don't know anyone, even people in the WHO, that don't think reform is necessary. In fact, the WHO right now is trying to instigate a reform policy, but they're not asking the hard questions, of course. But even they know they have to do something because the model isn't working. Leaving the WHO would leave a lot of global common goods off the table. And I think that that would actually harm the interests of many states, including the United States, but certainly those that have high disease burdens where the WHO does a lot of good, right?
Hmm.
So there would not be a malaria program in the DRC without the WHO. It just doesn't have the capacity or the infrastructure to do that because of its situation of being in a constant conflict
Hmm.
and high levels of poverty. 70,000 people already die around that number die of malaria a year in DRC. It would be significantly higher if the WHO wasn't there. So, on a moral level, you would say, well, do we want to allow that to happen if we don't have to allow that to happen? And I think
Hmm.
the answer for most people would be no, as long as it's been done reasonably and
Hmm.
we can rely on it to be a reliable response. Data collection, data sharing, standardization of data, these are all important things the WHO does. What you don't want is 194 different standards of data collection, data management, data usage. We won't be able to get a grip on what disease burdens or what threats there are to our countries, right?
Hmm.
Because the data would be so bad. It's already bad. And that's
Hmm.
with them trying to do it. Um, and they, last 20 years have seen a lot of improvement. But there's still a lot of improvement that needs to be done. So I think there are global common goods that the WHO could provide. It is also an existing body that has a World Health Assembly, one country, one vote. It's imperfect. Power has gotten in there. It's lost its focus. It's drifted. I don't think it's accountable enough. But the mechanism is there if it was reformed properly. So my point was we might want to think about reforming it. We may have to think about replacing it if that doesn't work, but we're going to need something. We're going to need an international health organization. We live in an unbounded sphere. It's inevitable that there's collective action problems.
Mhm.
It's inevitable that we have to do something. So, yeah.
And so that kind of leads into the work that you're doing with the International Health Reform Project, yes?
Yeah, that's right.
Okay. Can you talk a little bit about that and what that work is about?
So the International Health Reform Panel is a panel of 10 people, different backgrounds. For example, a former Assistant Secretary General of the UN is one of the co-chairs. So people with different backgrounds, with different sort of policy experiences, academic approaches, points of views, ideologies. Some of our meetings were quite battlegrounds actually, and our job was to uh, how if what would an ideal international health organization look like? So to figure that out, would be the ethical principles? What would a constitution look like? What would be its public health function? What should be its priorities? How would it do hiring? Everything.
Mhm.
It's extensive.
It
It's nearly 500 pages of report, and then measure it against the WHO in practice. So we can identify gaps between what you would want an international health organization to do and what the WHO does, and why we might want to be thinking about those type of reforms to get it more towards the ideal. Um, there's 2 reports. One's a policy report that focus more on the policies of it, and one is more of a technical report that focuses in detail on everything from staff mobility, hiring practices, financing, to, uh, accountability systems, the whole thing.
all the nuts and bolts.
Yeah, and it relies on existing evidence, existing reform debates, but it also, relies on the WHO practice itself. So we could find elements and then measure it against the ideal health organization that we modeled in the first part of the report.
Okay. And would that also take into consideration like public health and the preparedness for a pandemic? Is that all one thing you're wrapping up into this? Like
Yeah,
it's
we do
because
have some of the insights from repairs show up in that report, but we wanted to focus mainly on global public health as a whole, and
Mhm.
not to give legitimacy to this fetishization of pandemics. So it's in there, but it's couched more appropriately as, hey, look, this is one thing you need within a global public health
Right.
portfolio. Um, it needs to be proportional. It needs to be fit for purpose. It needs to be financed well enough, but it doesn't need to be overly financed. So
Right.
we kind of go through that.
Mhm.
The key takeaway, I think, there's lots of interesting takeaways in there, and lots of reform recommendations we have, and I encourage everyone to look at it. We have smaller versions of it, like executive summaries. So
Mhm.
because no one wants to read 500 pages.
I'll put all
Um,
those in the show notes.
that would be great. Is the way the WHO has been financed and how that allows it to have drifted. And prior to the 1980s, about 80% of the WHO's operating budget came from assessed contributions, which is contributions from the states relative to their GDP and
Mhm.
population size to fund the WHO as an independent entity in the benefit of 194 states, right? Makes sense. It's like a tax system,
Right.
right? Um, reverse that now in the current order. Right now, around 80 to 82% of the WHO's operating budget comes from what's called specified voluntary contributions. Now, these are contributions from any entity that are specified for certain programs directed by the funder. So this means that a large funder can go to the WHO and say, I'm going to give you this number of millions of dollars, but it has to be for this, implemented in this way. And so what the WHO has become when 82% of their budget is dictated by specified funding is
That is
to
a
follow the funding,
right. So they
right?
become sort of an arm. They form an implementation arm for whoever is funding it. That is
Even
a
worse,
big that's
they
a
become
big
the
flip.
normative arm. They become the normative arm because they set the policies. I know everyone says, well, the WHO, and this is clear, WHO has no legal authority to dictate policy to states. None. And even in the pandemic agreement, there is a new article in there. I think it's 22.2, but I might be wrong, that specifically says that the WHO cannot dictate uh, response policies to states. All they can do is make recommendations or provide guidelines, but they cannot force states to do that. That is perfectly clear in the Constitution. It's also perfectly clear in the pandemic agreement. And that was an addition that the WHO had to make because states were barking so much about, restrictions to sovereignty, etc. Um, so the WHO can't do that, but what they can do is set normative guidelines, policies, and those are picked up by the World Bank and the IMF as part of the UN system. And they're also picked up by the Global Fund. They're also picked up a little bit by Gates and Wellcome. They set the standards and the norms. And those groups have funding. And then those groups say a condition of getting this loan from the World Bank or this grant from the World Bank is you have to do XYZ, which
Right.
falls in line with the WHO guidelines. So although the
Which have been, promoted by the private funder.
yeah. So we
Okay.
have a form of economic power, which is a form of, they say, soft power, but I think it could be quite hard power if your entire survival depends on it. So let's take something like Zambia. There was a time in Zambia's history where 47% of its health budget was externally funded. Now, if your external funder says you do this or you don't get the money, you do it,
That's
even
right.
if it's not one of your health priorities. And we've seen this time and time again with health programs where someone gets a pet project, they put a lot of money behind it, and states are like, we'll take that, even though we don't need it. Or we'll change our national strategic plans for the next 5 years to incorporate that because
Wow.
more money is better than no money, right?
Right.
So it the WHO doesn't have the direct power, but it has the normative power, it has the policy power, it has the convening power, and then through its proxies and its associated bodies, it can dictate economic power, and that can force states to do some pretty stupid things. Yeah,
And now 80% of the funding is from what did you call it again?
a specified
A
voluntary
specified amount,
contribution.
okay.
Yeah.
Alright, and I would imagine that is one of the reforms you would, specify in your work on
It's simple.
what
If you were
should
to
yeah,
Yeah, if you were to make an independent international health organization from scratch now, would you set up the financing that way? No one would. It would be a non-starter. Why do we have it now?
yeah,
If no one in their right mind would ever set up an organization like that, that's meant to deliver global public goods.
right.
You just wouldn't do it. It just doesn't make any sense. So I mean, that's the most hit you in the face sort of finding that we did when we looked at the who was financing the WHO and how. And you see that and you just think, and states can also specify their funding, and they do that to benefit themselves. And there might be some logic to that. For example, the German government, the surveillance biohub, the global biohub for pandemic surveillance is in Germany,
Right.
underwritten by the Germans through specified funding. Why would the Germans want it? Because they have a massive pharmaceutical industry, right? So of
Right,
course they would want
right.
to have that biohub embedded in Germany,
Mhm.
in partnership with German pharmaceutical companies, which
So
they
they
are.
can specify their
Yeah.
contributions go to that, right?
So the
Um,
states do it all the time too, but Gates does it, on whole, en masse. And there was a BMJ article recently that came out and said, okay, well, let's follow the money. What does he actually fund? It's all technical and biomedical solutions and some stuff on polio. Nothing on health system strengthening, nothing on nutrition, nothing on social determinants of health, nothing on
Solving
what
any problems, it's
the bread and
treating
butter of
problems.
WHO. Yeah,
Yeah,
it's
yeah.
symptom based, exactly.
Right, right.
Yeah, it's fighting symptoms, not causes.
So this
Um,
w go on.
yeah. No, no, no.
The work that you're doing then, to reimagine what a global public health organization should look like, when that product is done from your work, what will happen to it? Who will see it? How much impact do you think it could have?
Well, it just came out last month. The 2 reports, I have one here, I can show a copy of it. This is one of the published versions of it. Um, you can get it for free online too somewhere. Uh, we have spoken to some parliaments, Australian Parliament, the British Parliament. We've had meetings with the Health and Human Services, with the State Department in the US.
Mhm.
We sent this out. I consult for a number of critical countries, meaning critical the pandemic agreement countries in Geneva, um, and they have it, and
Critical
it's
as in they are
critical of
criticizing, not that
y
they're essential, they're
no,
criticizing.
no, they're
Okay, I just
non-essential, that's part of the problem.
okay, I just wanted to make that, distinction.
Yeah, they're non-essential, and I think that's what they're finding frustrating because their voices aren't heard, and they're getting steamrolled
Mm.
by a process that has a lot of weight behind it. Um, the EU, the G6 countries, not including the United States anymore, um, and, a few other pharmaceutical giants like China and India. What are you gonna do? I mean, that
You can't get to the
if you get
table.
the BRICS and you get the G7 and you get the EU together, you're out of the loop. So, that's but I'm there trying to help as best I can.
Mhm.
So we're getting it to some people. We've done some editorials, we've published some stuff, but, we're finding a lot of pushback in this space because it's not in the interest of the WHO, and it's not in the interest of a lot of other organizations that these type of reforms take place. So we're relying on those that really want the reforms to take place to push it, and like I said, they're the non-essential, uh,
Smaller
global players.
entities.
Yeah,
Yeah.
but, some have shown some interest, and I think are quietly pursuing it, or they'll reference it as evidence when they need to make a point with
Mhm.
a negotiation. So that's sort of where we are now. It's early days for, the WHO work because that report just came out. The repair stuff on pandemics has had much more traction and has gotten in more people's hands and has been placed into evidence in some of the negotiations, and, even the WHO has listened to me on that, because 'cause they're not everyone who works at the WHO, some nefarious person.
Oh,
A
of
lot of
course
people are
not.
doing some very good work, and, when they're shown to be wrong, they're willing to accept that. Now, the higher ups may be politically entrenched, not and disincentivized to do that, but the people on the ground are like, "Yeah, I don't want this program to fail, so please
Mhm.
tell me what you got," you know? Yeah, so it's getting some traction. Not doing too
Um,
bad.
no, I
We
think
need more.
it's we need more of that kind of work, yeah, the work that's not incentivized by, big forces who have
Yeah,
agendas that might not be public health, you know, related
and I think
necessarily or public health primarily, motivated.
absolutely. And the timing sucks too. The day we launched this, Ken Steimer was up against, prime minister questions to oust him from the Labour Party, and we were in Parliament, and so that completely took over the narrative. And the report comes out, and a war with Iran starts, and that totally crowds
Ah,
out any media attention we can get. So we had some news outlets, major news outlets, say, "Yeah, yeah, we're interested in this," and then they said, "Look, we got to prioritize the war in Iran.
right.
We got to prioritize XYZ." And just I don't know what's going on in the world, but just when you think things might calm down, there could be some open air to breathe. Something else just fills
Yeah,
the void,
yeah.
and
No, that's what it feels like.
I don't know if that's social media or online information or what's creating this sense of constant calamity, but, I you know, whatever happened to the days where you're just kinda like, "God, this is a pretty slow news cycle."
Yeah, I don't I with you. I don't know if it's intentional. the
Mm,
algorithm, but I do think us being glued to a screen 24/7 as a society. I mean, like Twitter, you used to be able to go onto Twitter and see what was happening in the world and get your news fairly quickly, and
mm,
now it's just way too much.
yeah,
I mean, it's like you're driving 90 miles an hour and you wanna focus on one thing and everything's a blur.
yeah,
Um,
I think that's right. So
I
we're
don't
up
know what to
against
make
that.
of it. Yeah,
Uh,
eh,
yeah,
given the current, landscape now, do you think one of these, outbreaks will gain some kind of traction to roll it into, some kind of state of a national or an international emergency? Because there is an apparatus maybe a little bit eager to go. If I
yeah,
and I don't mean to, but I do think there are financial forces. Um, and again, I don't think it's a group of guys in a room with cigars, but if you have 10 vaccine companies who are ready to go with an mRNA shot for the next pandemic,
yeah,
there's going to be an eagerness
yeah.
to do that. Do you think it's possible um, that we're going to find ourselves in that kind of situation soon because of the media snowballing it?
I think this, there's a word for it. It's called the securitization of health. And basically, that is when interests change the narrative in a way that creates a heightened sense of emergency, of security, which then can justify extraordinary measures. And this securitization has happened long before COVID, and there's plenty of documentation that shows that. In fact, one of the things I did in the report is I looked at all the work packages of the WHO going back and see how securitization, how the agenda swayed and moved towards this sort of prioritization of health emergencies and security. So it's happened before COVID, but it's certainly accelerated since COVID. And it's a good question. I do think that we have primed ourselves now for uh, the answer to all the inquiries on COVID was we didn't go fast enough and hard enough. So we primed ourselves for that. And my fear is that if anything looks a little bit worse than the hantavirus, we're going to start seeing some crazy responses
Mhm.
that are knee jerk, policy of no regrets, quote unquote, is what they're calling it, where out of abundance of caution, and the harms will be far more than the benefits. And I want to get back to that if you can remind me. Um, tie us all the way back to the evidence base. That said, there is a skepticism. Trust in public health authority has never been as low as it is now in the length of time they've been doing these surveys.
Mhm.
There's way more skeptical voices. Even those that were skeptical during COVID, they're more skeptical now, and those that weren't skeptical, at least a good percentage of them have become skeptical. So there are people out there that are just like not willing to play along with that playbook. So I don't know if that's gonna butt heads or they'll get steamrolled or they'll get canceled or whatever again, but I'm not sure how those dynamics are gonna play out. But I
Mhm.
certainly think that the institutions are primed.
Mhm.
I mean, if you just follow the money, what have they actually put in place since COVID? What are the institutions and what are the financing? Well, they set up the pandemic fund and it only provides funding, grants for surveillance, diagnostics, and human resources for those two activities. Then they set up the surveillance biohub in Germany to collect those samples and to try to find emerging threats. Then they set up the 100-day mission, and the 100-day mission is out of CEPI, and that is to find a vaccine within 100 days of declaring a pandemic emergency.
What is CEPI?
CEPI is the vaccine countermeasures global institution, whereas Gavi is the distribution of those. CEPI is the
Okay.
research R&D side of it.
Okay, so
Um,
they're ready to go in 100 days.
in 100 days, what could go wrong? And then,
I
and
think we
then
already know what can go wrong.
And then they've
Sorry.
changed their, managing epidemics handbook, and so the handbook now says you can do all these things we did during COVID, where those were excluded prior to COVID, saying that these can cause more social and economic harm than good. Those have been kind of changed. We did look at that. We have a paper published on the lessons learned. And then they're going to create a replacement for COVAX, which is the vaccine distribution system used during COVID, within Gavi, so that when those countermeasures are produced via the 100 days mission and the pharmaceutical capacity that we're going to have in readiness,
Mhm.
and distribute those um, to countries that may not be able to afford them. So that's just the same old playbook. That's a very biomedicalized way of thinking about preparing for pandemics. It does nothing on prevention, zero. It does, and it's not preparing health systems. It's not preparing people.
It's not making
Or,
anyone healthier.
and so, healthy systems and healthy people are more resilient people and more resilient systems. And that has to play a role in any pandemic preparedness if you're going to take it all seriously. And if you're really worried about it, the threat is so big, you would need to include that. And that's just not there. So the playbook looks the same. So we have primed ourselves for that kind of biomedical response. And I think, what do we do during those 100 days then while we're waiting for the vaccine discovery?
I think we might lock down, Garrett.
Good. We could, but then I think that's where you might get the major pushback, right?
Yeah, yeah.
Uh, it would be amplified to what we saw during COVID. Whether or not that would make a difference or not, I don't know. But I think it would be amplified now because, people who were in good faith going along with it for a while, thinking like, okay, I don't want to be a jerk.
Right.
This is so bad. And then, the clogs started clicking over. And then you're like, well, wait a minute, this is absolutely dreadful.
Yeah,
So there's that. But to get back to the cost really quick, because I think this is
yeah.
important. This is something that when we looked at the costs of the pandemic and the risks of pandemics, one of the things we did is looked at like I said, the return on investment. And the return on investment is anywhere between 14 trillion and 27 trillion dollars, if depending on what you think the full cost of the pandemic cost. But the problem of doing return on investment calculations like this is it doesn't disaggregate direct costs of SARS-CoV-2 from indirect costs of policy response. It lumps them all together. So direct costs would be the cost of hospitalization, the cost of lost wages due to illness with the actual virus.
Actual illness, right.
Yeah, therapeutics, direct costs of addressing uh, the
Sickness.
virus, right?
Yeah.
Indirect costs are lumped into that. Indirect costs include lost GDP, right? So of course it's going to be 27 trillion. Uh, stimulus packages.
Oh, which
Um,
which doesn't
well,
probably take into account the following inflation that happens after that, but
yeah, our welfare, social nets. Those are included too. And I'll give you an example from the UK because I think it's the most ridiculous thing ever. There was a scheme here called Help Dine Out to Help Out. And as the lockdowns came to an end, the hospitality sector had crashed. So the government would cover 50% of your dinner bill, including one drink, if you ate out. And they spent hundreds of millions of pounds encouraging people to eat out and subsidizing your meal by 50% as a way to give a stimulus shot into the restaurants. Now, whether or not you think that's a good idea or a stupid idea, I think it's a stupid idea. Don't have the lockdowns in the first place.
that's
Um,
exactly it.
but that's included in the
In the
costs.
mm,
So there's no way of disaggregating dumb policy responses that were incredibly expensive with really bad economic impacts from the cost of what we maybe could have done. So we
right.
don't know. But so when you hear this, 5 years of 31 point billion per year will save you $27 trillion based on IMS and estimates of total cost of COVID. That's just another razzmatazz that I was talking about.
Yeah,
Like,
yeah,
first of all, it's never going to be 100%. You can never mitigate 100% of costs. There always going to be a cost to any outbreak. It's the nature of the beast. But then to also just say that the cost included everything, even really bonehead policies like dine out to help out, um,
yeah.
that's just it's ridiculous. So that brings it all back to what the work we're doing. The work we've been doing is trying to expose these weaknesses in the evidence and therefore the weaknesses in the narratives that
Mhm.
are being given. I'm not anti-vax. I'm not anti-pandemic preparedness. I think it's sensible to prepare
Sure.
for outbreaks because history has shown that they do occur. I do think that these things matter, but my underlining drive is the key to you living a flourishing life, to having any minimally decent life is your health. And that can be impacted by lots of things
Right.
and lots of systems and lots of sectors and lots of, compounding elements. And to put all of our eggs in one basket out of fear or an anxiety that may not be necessary will harm that general well being and that ability to live a minimally decent life for many people and a flourishing life for the rest of us who are lucky to have that minimally decent standard already met. And that's what has driven me, um, to do this because when I got smacked in the face after doing that report, I just thought that I'm embarrassed by this. Someone needs to look at this. And I
Mhm.
pulled together a team that was willing to do it. And boy, we thought 2 years and we would be done. We had to add a third year because we kept finding more stuff.
Right. Yeah, because you
It's
were
just
looking
unbelievable.
and I don't think if the media were doing their job, they would also be looking for these things. They would be investigating and going deeper into the numbers. So, it's
Or
a
at least picking
heroic.
it up with someone who's done it,
Right,
right?
right, right. Yeah, so,
Uh, because it
it
was painful. Trust me, I don't wanna read these reports and look at data sets and
yeah,
go recrunch the numbers and, unpack a graph and try to, figure out how they did their scatter plot. All that stuff is
right,
incredibly painful. I get it, but when someone hands it to you on a platter, you can dismiss it, but you read it first and say, "Okay, if
right.
this is real, there's a problem. If it's not
Yeah,
real, then these guys are ideologues or something."
right.
And this is what happened when we got that peer review back. The guy just said, "These guys must be crazy ideologues because there's no way the World Bank would have done a return on investment this way."
Yeah,
And then we handed it to them, and they were like, "Oh, shit, they did it that way?
yeah.
We gotta publish this because this is just sloppy on top of slop."
Well, I wanna
Crazy.
include all of the relevant things in the show notes so that the people who are listening to this can get either an executive level summary or dive a little bit deeper. And you can let me know all of the things that I should include, but where can people find you, um, if they're interested in finding you?
If you were to Google my name, Garrett Wallace Brown or Garrett Brown. Garrett Brown's a professional athlete somewhere, and he's also invented the Steadicam, so you might wanna put the Wallace in there because
Okay.
the guy who invented the Steadicam is, like, super famous, and you'll get him first. But if you find my, profile at the university, then there'll be links to at least the repair reports,
Mhm.
and hopefully you can put links to the,
I will do that.
IHRP. That's not a university-led project, that was something I did on my own,
Okay.
so it won't be on my university site, but the
Okay.
university holds the grant that provided all the pandemic stuff, and that
Okay.
also means it's incredibly well vetted because it's such a controversial topic that we had to put
Right.
together an advisory board, which had to be chaired by the director of research for the university just to make sure that we protected ourselves.
Sure. Which really adds a lot of credibility to the final product. So,
Yeah.
um, let me ask you, what advice would you give civilians who are moving through the world right now, reading whatever media they're reading? What would you, how would you suggest they think about an emerging pandemic in the media? What questions should people ask? If you could give a little parting advice, like what's the best way to have discernment in these matters?
Um, I mean,
Not to
how
put you
I
on the spot.
well, I'll just kinda say how I do it. I try to find in the media reports or in other sources, if possible, a breakdown instead of looking at just whole numbers, like this number of people have contracted X. I try to look at hospitalizations and mortality associated with that. because that will tell you more about the severity of it. You can
Then a
have
positive test.
yeah, you can have
Yeah.
highly infectious, pretty, you know, all things are dangerous, but, they're not they're not super dangerous, but they're highly infectious. So, if someone says, "There's been 10,000 new cases of X," that sounds bad.
Mhm.
But then if you look at the numbers and say, "Yeah, but of that, um, only 3% have been hospitalized and there's only been 2 deaths," then you can say, "Okay, well, this is not super scary." So that's the first one. Just the media will use any headline that will grab your attention, and so you just have to unpack it a little bit, and that's how I do it first. The other one is location. If it's on a ship and people know it's on a ship and the ship hasn't gone anywhere, it's been to Antarctica, I don't think you need to worry about it yet. Unless these
Mhm.
things can independently swim across the Atlantic Ocean, I don't think you need to worry about it yet. And because of the media attention and the attention, you can be pretty assured that if there is a threat, it's going to be responded to. It will probably be overkill, if anything. Um, there's that. And I guess the last thing, what else do I do when I see these kind of things? I mean, the nature of the transmission is always important. So, there was a headline, this is how the next pandemic starts, and it was on Mpox, I think it was. You have to come in contact with an open sore. It largely infects prostitutes, those who visit prostitutes, those engaging in high risk sexual behavior without condoms, and babies who have to nurse mothers who have the disease. So you can be pretty okay that this is not going to be something that you're going to breathe in on an airplane. But the media may not tell you that because you'll just see the headline. This is how the next pandemic starts. Right?
Mm.
We're ignoring mpox. Um, but in the long run, traditional public health measures have gotten that under control by and large. Uh, and we didn't need to vaccinate at a cost of 1.3 million per life saved to save 300 people with a smallpox vaccine. That was what was being argued almost instantaneously
Mhm.
after that outbreak. Myself and some others wrote some stuff in the Lancet saying, "Look, it just doesn't transmit like that, and you can use these cheaper public health programs to kind of get ahead on it."
Right.
And that's what happened, and we
Yeah.
were proven right. But yeah, if we would have spent that money, we would have spent well over around 400 million to save 300 lives, and who
And
knows
also
if we would have gotten on top of it, you know?
you end up, bringing to market a product, and maybe not in that specific case, but in another case, you'd bring to market a product that isn't sufficiently safety tested because it couldn't possibly be.
Yeah.
So the argument that the countermeasure is safe,
Well, they didn't
you
even
just
know if it would work. They knew it would
yeah.
work for one of the
Oh, safe
Clydes, but
and
not
right,
the more
right.
deadly Clyde. They didn't even know, so they were like, "Well, we know it works pretty well for one,
So
so,
why not?
it's like,
Um,
we'll do some testing. If it turns out that it's just the most amazing product in the world and we want to spend that money, then let's do it." But
right.
you have to build the argument for it, and you just
Yeah.
so the knee-jerk reactions, I guess what I'm trying to say is the headlines are always going to be misleading towards the erring on the side of catastrophe in
Right.
order to get your attention.
Yeah.
Pictures of British troops jumping out of airplanes. I mean, that sends a, "Look, you better click this.
Right.
This is how bad it is." Um, questions about the shouldn't go traveling to Tenerife because the ship is docked there. Well, how does it spread
Right.
actually? And
Right.
you
Right.
think anyone was dumb enough to let those people off the boat?
Right.
Like, come on.
Well, I think this is the world we live in, but hopefully people are getting a little fatigued of that and won't engage quite as much. So yeah,
It's hard not to though when it's
it
in your
is.
face.
It is really hard not to, but we can all try. So, Professor Brown, Garrett, thank you so much for taking the time.
Yeah.
This has been very informative for me, and I think people who are listening will learn a lot from it.
Yeah. Well,
So,
thank you for inviting me. It's
yeah,
great. I always love talking about it. Hopefully I didn't motor mouth too much.
no, it was great. You're perfect. So, thank you so much, and I hope that our paths will cross again soon.
Yeah, I hope so too.
Okay, thanks. Bye.
Bye.